some of you on that. We also have a special offering this month on March 10th and the 17th, which is for those fundraisers out there. I don't know if we have any fundraisers in the room. I know we have public health people in the room, but fundraisers out there. And we are having a session on Planned Giving 101. So that's something new for us to be offering. And if you know anyone in your development office that might benefit from that type of programming, please go to the Together SC website and join us for that. With that, I think I'll get started because we have a really important topic today. As we said, it's been a year now, more than a year actually, as we've been in this pandemic. And, you know, there's light at the end of the tunnel. There are vaccines out there. There are folks maybe even in the room that have already been vaccinated. There are people that are in the next phase of vaccines, and there are people that are awaiting vaccines. So we're going to learn all about the COVID vaccines. We're so lucky to have this opportunity to do this. This is a session that's out of the normal time that we do Together SC sessions. It's 2 o'clock on whatever today is, Wednesday. So we're glad many of you were able to join us, but we felt it was that important that we wanted to bring it to you as soon as we could. The reason for our topic came from a dear friend of Together SC, Dr. Graham Adams, who has a long history with and he's waving, a long history with Together SC, and he is actually the CEO of the South Carolina Office of Rural Health. And as you can imagine, in the organization that he leads, this year has been a extremely busy and pressing year for them in the work that they're doing, and have had a lot of work in the planning going on around our state about how to gain access to COVID testing and healthcare facilities, and now, of course, the vaccine for our rural and underserved communities. And in his role, in that leadership role, he has had, I think, many crossovers with the South Carolina Department of Health and Environmental Control, as we call it, DHEC. And so Graham had suggested to us, why don't we get one of our wonderful state epidemiologists to help us share information about what's going on with the vaccine. And that's how we got introduced to Dr. Jane Kelly. So I'm going to turn it over to Graham to do a brief introduction, and Graham's going to help facilitate today, and we're going to learn as much as we possibly can about these various COVID vaccines. So Graham, take it away.
Thank you, Debbie. Thanks, Ben. It is my pleasure to join y'all today. I have a soft spot in my heart for Together SC. When I was the president, it was called ScanPo, but that was a while back, and it continues to do good work. I do think that we have a great opportunity today to really learn a lot about COVID, where it is in our state, the trends that we're seeing, and specifically the vaccines that are available. My office, and I know a lot of members, have been involved in the vaccine advisory committee and different ways trying to partner with DHEC and trying to partner with hospitals and health systems and rural providers to make sure that testing was available in rural communities, and certainly as the vaccine becomes more available, that those vaccines are available throughout the entire state. I know there's been a lot of questions from not-for-profit leaders like you about where you and your employees stand in the phases. We'll get an update on that. I run a not-for-profit, and I get a lot of those questions from my staff as well. Dr. Kelly's been a great resource for the vaccine advisory committee. She's been very engaged in working with communities, and I am on calls with her pretty much each week, but I've heard her do presentations as well. And she does a wonderful job of really explaining the history of the vaccine and the fact that folks have been working on this vaccine for a long, long time, not just for the last 12 months. So I think it's going to be a great chance to really hear the latest. Things are changing very, very often and quickly, and news develops fast. So we have one of the state experts, and I'm thrilled to have her. So Dr. Jane Kelly is the Assistant State Epidemiologist for DHEC. She spent a lot of her career at the CDC. She's an internist with more than 35 years experience. She's done work internationally, and retired recently, but came back to help with the pandemic and was called into service. And she's just been, again, what a wonderful resource for our state in helping folks to really understand the vaccine. And hopefully we'll get to the point at the end where we'll have the opportunity to ask some questions and see how not-for-profits like yours can be helpful in trying to message why it's important to get the vaccine and issues around safety and possible reluctance that folks in your community may have. So Dr. Kelly, I'm going to turn it off to you. Do you want to kind of have me interrupt as questions come around, or do you want to kind of wait till the end?
I guess I would suggest that people put their questions in the chat box. Mm-hmm. I think that'd probably be that way you can put them in as you're thinking of them. You don't have to worry about waiting. But I think it might flow more easily if I just go ahead and give the presentation. Great. I might answer your question in my presentation. But if you put them in the chat box, and then we can address them at the end.
Fantastic.
And thank you for that kind introduction. I'm going to go ahead and share my screen. Hang on just a sec. I've got a bunch of different slides up. Okay, I think you can see that messengers and Trojan horses COVID-19 vaccine update. What I plan to do is to give you an update overall on the disease COVID-19, talk about vaccine safety and efficacy, the new virus variants, and finish up with talking about vaccine hesitancy. This is a graph that shows depicts the epidemic for the nation as a whole, but it really does also parallel in recent months what's going on in South Carolina. We had a huge peak after the holidays in mid-January. And for both the nation as a whole and for South Carolina, we have then had 7 weeks in a row of a downward sloping trend, thank goodness. So we've got decrease in number of cases, deaths, and hospitalizations. The only thing that makes me a little nervous, and this is true for South Carolina as well, you see that little plateau at the very end? It feels a little bit like people are rejoicing that their vaccine is here, and now we can loosen up our mitigation measures, masks, distancing, etc. I'm going to talk about why it'd be very important not to do that yet. We need to maintain the gains. We need to not loosen the pressure. We still need to keep our guard up. A little bit of vocabulary words, because sometimes these terms are used interchangeably, but they do actually mean different things. Coronaviruses are a family of viruses. Some of them just cause the common cold. SARS-CoV-2 is the name of the virus that causes the pandemic, and COVID-19 is the name of the disease that the virus causes. That little cartoon shows what the virus looks like under the electron microscope. The coiled line in the middle, that's the RNA. We as mammals, we have DNA in our genetic code. This virus's genetic code is a related compound called RNA. Surrounding the genetic code is a lipid protein coat. And the most important protein for this talk is the spike protein. And the reason it's important to know all that biology is I think it helps you understand the vaccines, the variants, and what are we going to do if some of these variants become the dominant variant in South Carolina or in the nation. The spike protein is important because it's the first step. It attaches the virus to the cell and injects the virus RNA into the cell so that it forces the cell to make new virus particles. Probably know the symptoms of COVID-19. Many people are asymptomatic, have no symptoms at all, or have mild symptoms, cough, fever, chills, muscle pain. Some people have more moderate symptoms, shortness of breath or difficulty breathing, sore throat, and a peculiar symptom that seems unique to this condition, a new loss of taste or smell. And a lot of these symptoms kind of overlap with influenza or even with the common cold, but not that one. That new loss of taste or smell is an unusual one. Unfortunately, some people do go on to have severe disease. And the reason for that is they get widespread vasculitis. Any word that ends in itis, medical terms end in itis, like arthritis, conjunctivitis, dermatitis, that means inflammation of that system. Vasculitis means an inflammation of your vascular system or your blood vessels. So you can imagine if your blood vessels are inflamed, that's going to affect every organ in your body. Yes, pneumonia is the predominant feature of COVID-19, but people with COVID-19 also can have heart disease, damage to their kidneys, liver, gut, brain. It can affect women who are pregnant and be transmitted mother to unborn child. So there are a lot of adverse events for fortunately for the minority of people who get severe disease and widespread vasculitis. Let's move on to talking about vaccine. And we have 3 vaccines to talk about today. But first, I just want to start with this cartoon that I like because I think it's an easy at a glance to help you understand how do vaccines work. Vaccines provide a sneak preview. So in this cartoon, you see a wanted poster on the wall that has a picture of the SARS-CoV-2 virus, and the white blood cells that make antibodies are looking angry because 2 of those SARS-CoV-2 viruses have just entered that blood vessel and they recognize it. So they are already prepared. They already have antibodies, and there's other things besides antibodies, B memory cells and killer T cells, but they're already prepared the immune system to go ahead and attack the virus immediately. Many people have asked that question of how is it possible to develop a vaccine that's safe and effective in a year? I mean, I thought it took years to make a vaccine. It took decades to make certain vaccines. How can we have a vaccine made so quickly? 3 basic stages to developing any vaccine: basic science research, testing it in animals, and then testing it in humans. But that basic science research, that's the longest step. Learning about the virus or bacteria that you're fighting, doing the research on figuring out how does its metabolism work, what's going to be the best place for us to attack when we make a vaccine. And that actually has been going on since 2003. Do you remember SARS-CoV-1, severe acute respiratory syndrome? Came out of China, affected about 8,000 people worldwide, killed 10% of them. They started work on a vaccine in 2003. Fortunately, SARS-CoV-1 was less contagious. So with quarantine, they were able to contain it, and we really have not heard from SARS-CoV-1 since then. But the basic science has continued. They may not have continued to work on a vaccine for SARS-CoV-1, but the basic science into coronaviruses has been going on for 17 years, trying to learn more about what it looks like, what is its molecular biology, I mean, its exact genomic sequence. Remember the Human Genome Project, 20 years ago, and it took $2.7 billion in 13 years. In 20 years, we've come a long way. You can get your genome, your personal genome sequenced for $1,000 in a day. So much progress has been made in researching SARS as well as advances in molecular biology. And what about the testing? I mentioned, okay, basic science testing, test it in animals, testing it in humans. What is this phase 1, 2, 3 testing in humans? Well, when SARS-CoV-2 showed up, China published on January 10th, published the exact nucleotide molecular sequence of the genetic code of SARS-CoV-2. They were able to develop a vaccine and get it in animals in February. They were able to do phase 1 studies in humans, young, healthy people with no medical problems, as early as March of 2020, after it was proven safe and effective in animals. So first you do a phase 1 study in maybe 100 people. You're just looking for safety issues. Phase 2, they were able to start in April, and they did it in a larger number of people, maybe up to 500 people. Again, you're looking for safety, immune response, trying to figure out, does it need a booster? How far apart should the shots be? But the biggest step in the human studies is phase 3. And this is the step that normally takes a couple of years. And the reason for that is a business reason. It's expensive to do these studies. So vaccine companies don't want to go ahead and recruit tens of thousands of people that they're going to have to pay for their time. They're going to have to pay for their transportation. They're going to have to pay for giving the vaccine and drawing their blood periodically. They usually develop vaccines in phase 3 in baby steps. Give it to a few hundred people, look at the results, see if you think you've got a good product, do it in a few more hundred people, look at the results, see if you think you've got a good thing. So usually phase 3 does honestly last several years, not for safety reasons, but for return on investment reasons. What was different with SARS-CoV-2 is that the US government and other governments around the world invested in vaccine. They either gave money directly to the companies, or they said, we promise, we will promise to pay, we'll commit to buying 100 million doses of your vaccine. So those companies didn't have to wait. They knew they already had the financial backing. So for example, for Pfizer and Moderna, they each recruited over 30,000 people in 2 months in the summer of 2020. That's what was unprecedented. No steps were skipped. They were overlapping, and they recruited many more people all at once. And in terms of who they recruited, I'm only going to give the example for Pfizer, but the same thing was true for Moderna and for the Janssen, or also known as the Janssen Vaccine. They made sure that they recruited not just in the United States, but in other countries. They made sure that they had tens of thousands of people. So Pfizer, in fact, recruited over 40,000 people in their phase 3 studies. And they made sure that they had diversity, racial, ethnic diversity, with recruiting African Americans, Hispanic Latinos, Native Americans, Asians, mixed race people. And for Pfizer, they tested it down to age 16 and as high as age 85. So they knew that this was going to be a vaccine that would be broadly needed. They also tested it in people who had multiple other medical conditions like diabetes, heart disease, immunosuppression, because they knew that this is going to be a vaccine that's not just a pediatric vaccine, something that needed to be needed to be proven appropriate to a much wider audience. All right, so how do they work? Pfizer and Moderna vaccines are very similar. They both have the same approach. What they do is they don't use whole virus. There is no whole COVID virus, SARS-CoV-2 virus in either of these vaccines. You cannot get COVID-19 from these vaccines. What they do is they took just the genetic code for the spike protein. Remember, the spike protein is the one that attaches to the cell and injects the virus RNA. So that it's almost like a key in the ignition to open or key in a lock to open a door. They take just that spike protein gene, and then they surround it with some other materials to, kind of coat it. And then it is a vaccine that can be injected into the muscle. It's taken up by the immune cells in your body, and your immune system responds by making antibodies as well as some other responses in the immune system. So that that's your sneak preview. So if you're exposed to the virus later on, your immune system can respond quickly. What are the other ingredients in those? They're called messenger RNA vaccines. Messenger because they're carrying the message, the gene for the spike protein. Well, they have that messenger RNA, the gene for the spike protein, and then they coat it with lipids, with some oils, some fats, so that the enzymes in your muscles don't just digest the RNA. And also some salts and some sugars to balance out the pH, the acidity of the vaccine. And an ingredient called polyethylene glycol, which is another fat. It's actually a common ingredient in over-the-counter laxatives. But I mention it here because it's probably this ingredient that's giving people some allergic reactions. There are no antibiotics, no preservatives, no mercury, no aluminum, no latex, no egg. I mean, what are the other things people worry about are in vaccines? They kept all of those things out, trying to make these vaccines as simple as possible. Both Pfizer and Moderna are 2 doses, and both of them give you 95% protection against any symptomatic illness 2 weeks after the second shot. So after the first dose, you may have some protection, but we don't really know how long that immunity might last. It's only after the second dose that's kind of a booster for your system. So for Pfizer, you get 1 dose, and then 3 weeks later, you get the second dose. For Moderna, you get 1 dose, and 4 weeks later, you get your second dose. And you're not considered protected until 2 weeks after your second dose. Each of us, in making a decision about whether we want to get a vaccine, have to weigh the benefits and the risks. This is a personal decision. So what are the benefits? Well, we just said the Pfizer and Moderna vaccines are 95% effective against any symptomatic illness. That's about as good as it gets. That's a really high vaccine effectiveness. Other vaccines like flu vaccine, sometimes some years it's as low as 40% effective. So benefit is high. What are your risks? Well, I'm going to talk about 3 kinds of risks. One is symptoms that you might have after you get your shot, severe allergic reactions, and the possibility of rare events. So let's take them one at a time. Common COVID-19 vaccine side effects are temporary, but I think people need to know about them upfront so they know what to expect. Usually they're worse after the second shot. Some people really have no symptoms at all, other than maybe a soreness at the arm where they were given their vaccine. But many people experience mild to moderate fatigue, feeling tired, fever, chills, headache, and some other symptoms. This should be temporary, should go away after 1 or 2 days. And if people who are having symptoms that last longer than that, it may be something else going on and they should see their healthcare provider and get tested. What about severe allergic reactions? Now here, I'm not just talking about hives or itching or soreness at the site. I'm talking about anaphylaxis, where someone has a severe allergic reaction where they're short of breath or they're wheezing or they feel dizzy, their blood pressure drops. That has happened in about 3 to 5 people per million doses of COVID-19 vaccine given thus far in the United States. And for comparison, it's about 1 to 1.4 doses per million people for flu vaccine. Let me restate that, sorry, I stumbled. 1 to 1.4 people experience a severe allergic reaction per 1 million doses of flu vaccine given. So yeah, it's a little bit higher than flu, but it's not unexpected. And it is a treatable condition. So we are recommending that people have the vaccine. It's not contraindicated unless you have had a severe allergic reaction to your first dose, then you shouldn't get your second dose. But the concerns about, yes, some people have had severe allergic reactions have prompted us to, any vaccine provider, whether that's a mobile clinic or in a hospital, they are all prepared to treat severe allergic reactions. They've got the medications. What about rare events? Isn't it possible that we wouldn't see some really weird long side effect until millions of people had gotten the vaccine? Yeah, certainly, that's always true. But 75 million doses of Pfizer or Moderna vaccine have been given in the United States as of just a few days ago. So over 75 million doses, and we're not seeing those rare events. Yes, there have been a couple of people, there have been some deaths that have occurred among people within, say, 3 weeks of receiving a dose of vaccine. Those cases are always intensely investigated. More than 2/3 of those cases were among nursing home residents who have many medical conditions. The investigations have revealed that people have died of heart attacks, strokes, other events that are not likely to be linked to the vaccine, but that is being closely looked at. There was also a physician in Florida who died of an autoimmune condition called ITP, immune thrombocytopenia purpura. It's a platelet dysfunction. And he developed ITP 3 days after he got the vaccine. Could the vaccine have caused it? Anything's possible. It seems very unlikely to have developed that within 3 days of getting the vaccine. But again, I would remind you, we're talking about one thing here, one thing there, as opposed to 75 million doses of vaccine given. Compare that to how many millions of people have died of COVID-19. So each of us has to do this risk-benefit ratio. I think these vaccines are as safe as any vaccine on the market. What about Janssen Vaccine? This is also referred to as the Johnson & Johnson vaccine. Johnson & Johnson is the bigger parent company, makes lots of different products. The laboratory, the pharmaceutical arm that made the vaccine is Janssen. So I'm going to refer to this as the Janssen vaccine, also because that's what CDC calls it. This is a little different formula. This does not use that messenger RNA. Instead, it takes an adenovirus, that's like a common cold virus, that they weaken, and they use it as a vector to carry in the spike protein genetic code in the form of DNA. So I've got a little picture of the Trojan horse because I think this vaccine is like a Trojan horse. Trojan horse story, you may recall, Greeks are fighting the Trojans, and the Trojans think that they have sent them a gift as part of a surrender because they sent this big wooden statue of a horse and they bring it into their fortress, but hidden in the horse are a bunch of Greek soldiers, jump out in the middle of the night, attack the Trojan and win the battle. So the idea here is that you've got an adenovirus vector, that's your Trojan horse, so that when your immune system sees it, it says, aha, I'm going to pick that up and make antibodies to it, but it's carrying also the spike protein DNA. So you cannot get COVID-19 from this vaccine either, and you cannot get the adenovirus disease. It's been attenuated, it's been weakened so that it can't infect you with a common cold. The nice thing about this vaccine is the fact that they changed it so it could use DNA instead of RNA. DNA is not as fragile. So this vaccine, you can keep it just refrigerated. It doesn't need to be frozen. It's stable in the refrigerator for months. So it's very convenient for trying to get it out to rural communities or to little mom and pop pharmacies that don't have special freezers or that might only need a few doses, not a lot of doses of vaccine. The other beauty with this is it's single dose. So it uses the same proven technology that has been used for other vaccines. Now, these are not common vaccines in our country. We don't have a whole lot of Ebola here, but this method of making a vaccine, this vaccine platform with the kind of Trojan horse idea, has been used for years with Ebola and Zika and respiratory syncytial virus or RSV vaccines. So it's been out there for years. We know that there are no long-term adverse events with this. The majority of people who've gotten the Janssen vaccine have only mild symptoms, milder than with Pfizer and Moderna on average. And it's received FDA's emergency use authorization. And in fact, in South Carolina right now, we have 41,100 doses. And we are making plans right now for where that is going to be sent. So what are the common ingredients in that Janssen vaccine? Well, it looks an awful lot like the slide I showed you for Pfizer and Moderna, because in fact, it is very similar. Instead of using that messenger RNA, it uses double-stranded DNA. That's really just a technicality, but they took that approach because that way it's going to be easier to get out to rural areas and honestly to the developing world as well. Otherwise, it's got salts, sugars, lipids. Instead of that polyethylene glycol, it has something called polysorbate 80, which again is used in a lot of over-the-counter products. The only reason I mention it is some people are allergic to that. Same thing with no antibiotics, egg, preservative, mercury, or aluminum. Well, how did it work? Janssen tested things differently than Pfizer and Moderna, so we can't do a head-to-head comparison, but let me try and explain. So this is this vector carrying the spike protein in. What they looked for was their goal was to look at preventing moderate to severe disease 28 days after a single dose. And what they found is it was 72% effective in doing that when they tested it in the United States, 66% in Latin America, and 57% in South Africa. Well, now that's concerning. That implies, in South Africa right now, 96% of the SARS-CoV-2 virus that's circulating is the South African variant, which we do have here in South Carolina. So it's a little bit of concern here, but let me go further. When you ask yourself, wow, 72% effectiveness in the United States versus 95%, who would want Johnson & Johnson or the Janssen vaccine? Eyes on the prize. It's mortality that is most important. The Janssen vaccine was 85% effective in preventing severe disease at 28 days after just one dose. There were 0 deaths and 0 hospitalizations in the vaccine group, including in South Africa. So it's highly effective in keeping you out of the hospital and out of the morgue. And that's the goal. There's some people who prefer to have a single dose. There's some people who would prefer to have milder symptoms after being vaccinated. This is a good vaccine. If your goal is staying out of the hospital and out of the morgue, this is just as good as the Pfizer and Moderna. And again, I would caution, I know people are going to be talking about comparing the two. Remember, Pfizer and Moderna were tested before these new variants were out there. Yes, we believe those vaccines will protect against those new variants, but in terms of comparing efficacy, I just want to encourage everyone to remember all three of these vaccines are excellent for preventing severe disease, and that's our goal. And in fact, the other vaccines that are coming up, Novavax and AstraZeneca, they all drastically reduce hospitalizations and prevent deaths. Well, I've been talking about deaths. Who is at greatest risk for mortality? Because when people make a decision about risk and benefit ratio, you also need to think about, what are my personal risks of contracting COVID-19? You know, am I exposed? And what is my risk of dying if I do get it? Age is the biggest factor. Increasing age is the biggest factor for COVID-19 mortality. Most people, 80% of people, just have mild symptoms. Some people have no symptoms at all, last about 2 weeks, and then they are done. Unfortunately, in South Carolina, we have had some mortality. 69% of those deaths were in people aged 71 and older. Almost 90% of those deaths are in people aged 61 and over. I mean, when you start looking at the younger than 50 group, there really is very low mortality. And honestly, that's mostly among people who have several other medical conditions complicating things. I know every once in a while there's the rare report of somebody young and healthy who got severe disease, and trying to understand what's going on with that. But mostly mortality is a function of age. And that's part of why South Carolina included in phase 1A people who are aged 65 and older, because that is the group that is at greatest risk of severe disease and mortality. So right now, we are in the last few days of phase 1A, which was workers in healthcare settings, a few other critical personnel, and people who are age 65 and older, as well as the people in long-term care facilities. The good news is we are ready to move to phase 1B. So people will start being able to make appointments starting on Monday, March 8th. You can't go in and make an appointment for you yet if you're in phase 1B, but you will be able to starting on Monday. Phase 1B will be for individuals aged 55 and up, individuals with increased risk for severe COVID-19 disease. And I can go through that list if you want to be specific, but it's on our website. This is the same list that is on the CDC website for people with increased risk for severe COVID-19 disease. And a lot of the things you might expect: diabetes, cancer, lung disease, liver disease, kidney disease, and a few other conditions, including HIV/AIDS. Also, frontline workers with increased occupational risk. And again, we can go into more details when we get to Q&A, but the concept here is that we're not looking at essential services like disaster preparedness looks at. We're looking at this from the point of view of frontline workers are people who work in essential services we need, but who have unprotected exposure, unavoidable increased occupational exposure to SARS-CoV-2. So maybe that's because they're the grocery store checkout clerk, and they are every day interacting with people less than 6 feet, people who are supposed to be wearing masks but might not be wearing masks, and if you're in a county that doesn't have a mask mandate. So the individuals at increased occupational exposure. Also, individuals at increased risk in settings where people are living and working in close contact. So that might be in correctional facilities, in group homes, but also some work settings where the entire workforce is at increased risk. For example, people working in the meatpacking industry. And also other workers who work in healthcare settings who, for whatever reason, didn't get vaccinated in phase 1A. Phase 1C, we hope, will start around mid-April, and that will be individuals aged 45 and above, and all the other essential workers. And that's where I've got the link in with that asterisk to the CDC list of categories of essential workers. So if you have a particular question about an entity, we're going to generally be going along with that CDC list. Now, of course, that list can't include every single occupation under the sun, but it's pretty thorough. I think people can figure out where they fit by looking at that list. Now I'm going to move a little bit to talking about variants. I need to update this map because we are now down to only 4 states that do not have the B117 variant. This is the one that's also called the UK or the British variant. So it is definitely here in South Carolina, as well as it's probably in every state. It just hasn't been documented in every state yet. B1351, that's also called the South African variant. Not necessarily because it originated there. Same thing with the B117. We don't like calling it the British variant because it didn't necessarily originate there. It's just that's the first place it was detected. Both of these variants are here in South Carolina. And what is important to know about these variants is they're not necessarily more lethal. They don't cause worse disease. What they cause is that they cause more cases because they spread more easily, not because you cough more or sneeze more, or you've got juicier particles. It's just that their spike protein sticks better. And therefore you're more likely, if you're exposed, to pick up disease. Will vaccines still work against these variants? Yes, for the British. They've tested it by not only in test tubes, but they've also, and we have had some people who have had the vaccine and been exposed to the British variant who didn't get sick. It will prevent, the currently available vaccines will prevent severe disease for the South African variant. But in South Carolina, we have had a few breakthrough cases. By that, I mean people who are fully vaccinated. They've had it's been 2 weeks after their second dose, and yet they got mild COVID-19, not talking severe disease, but they got mild symptoms and tested positive. So the vaccine will work for preventing severe disease, but for some of the variants, it might not protect against mild disease. And that is why it is so important, even after you're vaccinated, that we still need to keep the pressure on. We still need, because these variants spread more easily and may cause more cases and therefore more deaths, we still need to wear a mask, stay 6 feet apart, avoid crowds, all those usual things, including if you've been vaccinated. And here's why. What did they test those? How did they prove efficacy? What did these vaccine companies look for? They looked for symptomatic illness. They didn't look for asymptomatic illness. So it is possible, if you've been vaccinated and you're exposed to SARS-CoV-2, it is possible that you could get COVID-19, have no symptoms, not know that you're infected, not know that you're contagious, not for forever, for that 10-day period, and risk spreading it to others. So until we can get more people vaccinated, we're still urging people, even after you're fully vaccinated, please continue to wear a mask, watch your distance, avoid crowds. Now, a word about more transmissible and why this is such a concern. And we're talking about, which would you rather? Would you rather a virus that's circulating from a population point of view, not just from you as an individual? Would you rather have a virus that was more lethal or more transmissible? This may not seem like common sense, that, gosh, I don't want to be more lethal. Well, let's look at the numbers. If you had that RT, that refers to that R naught or R time, that has to do with the biology, how contagious something is. So let's take first row and the black one and the red one, about the same level of contagion, but the red one, higher mortality. And then let's go, transmission cycles 3 months later, and we end up with, they each caused about 5,800 infections. But the higher mortality led to a little bit of increase in the number of deaths. Now let's compare the black one and the blue one. The blue one has the same level of mortality, but a more transmissible. 3 months later, holy moly, you've got over 300,000 infections. And of those, certain percentage of them are going to die. So now you actually have an increased number of deaths, not because the virus is more lethal, but just because it spreads more easily. let's finish up with talking about vaccine hesitancy. Vaccine hesitancy is true for all vaccines, and there's a continuum. There are some people who are anti-vaxxers, they just refuse all vaccines, that's that. And then it depends, some people will take all vaccines and readily embrace them. And I'm probably fall in that category. And then there's some specifics around vaccine hesitancy, sort of like some parents are hesitant about giving their 11-year-old child the HPV vaccine because they feel like it's not needed yet. I think there are a number of odd bits around vaccine hesitancy with the COVID-19 vaccines. Some of it is they still feel like it's been developed too quickly. They haven't heard the whole story of basic science research is the longest step, or they feel that it was politically pushed forward too quickly, or they think, wait a minute, this RNA vaccine, DNA vaccine, that doesn't sound right to me, not realizing that actually those things have been in use in other countries for years. But there are also some very specific reasons for vaccine hesitancy across racial and ethnic groups. Unfortunately, it is affecting the number of people who receive vaccine such that we have much lower vaccine uptake among people of color. So this is based on national data. This isn't specific to South Carolina, but South Carolina is experiencing the same thing, that based on this national survey, Black people were 52% less likely than white persons to be vaccinated or to have a definite plan, to be definitely planning to get vaccinated. It's also lower for Hispanic Latinos. So what do we know about this? This is from the Kaiser Family Foundation tracking poll, where they were looking at, in this survey, looking at who reported that they would want to get vaccine as soon as possible, wait and see, only if required, or definitely not. And as you can see here, African Americans or Blacks were more likely to be hesitant about COVID-19 vaccination. Nearly 2/3 of them were vaccine hesitant. One positive note, though, is that it's improving over time. So this is a contrast of what they did with that same tracking poll in August and September compared to November and December. And in all racial and ethnic groups, there was an increase in the number of people who said, I definitely or probably will get it. And therefore, of course, a decrease and probably definitely would not get it. So this is a positive trend. And I'm hoping that as time goes on and people see, well, 75 million people have gotten this vaccine and they seem to be doing okay, that I hope that this will continue. But I want to focus a little bit more closely on some of the reasons why people of color may be more vaccine hesitant. And I know I'm probably telling this story to people who know this already, but I share this slide in case, as you talk to other people, any of these slides are useful to you, please use them. Again, I'm sure you're all aware of the infamous syphilis study in Tuskegee. Tuskegee went from 1932 to 72. It started out supposed to be just a 6-month study where they were going to look at the effects of untreated syphilis. At that time, 1932, there weren't any good treatments. I mean, they sometimes gave people heavy metal injections, mercury injections for syphilis, but there weren't any good treatments for syphilis. And this was, they wanted to do a physical exam on African-American men with syphilis living in Tuskegee, Alabama. It was meant to be a one-time thing. It ended up going over 40 years. And the egregious thing that happened is that when penicillin was identified as treatment for syphilis, these men were not offered penicillin. In fact, they were actively discouraged from leaving the study to seek help at a clinic nearby that was offering penicillin. They never signed informed consent, wasn't a thing in that time, but they were never really explained in a way that would be understandable to them what was going on. There was a whistleblower in 1972 after this terrible event, which leads to this day mistrust in the medical system, the government, mistrust in pharmaceutical companies, fear of being used as guinea pigs. About the only good thing that came out of this was systems were set in place to help prevent this from happening. Institutional review boards, guidelines on ethics, human study reviews, informed consents, ongoing oversight during studies, ethics trainings that are required. But whoops, hang on. But I think we also have to ask ourselves why to this day are death rates from COVID-19 3 times higher for people of color. Sorry, there's a typo there, of color, because it's not simply that they are more likely to have diabetes, heart disease, obesity. It's not only that they have higher poverty rates. It's a combination of reasons. It may be that they have less access to medical care, but they may have more of a delay until they go to get tested or in seeking hospital care. For those reasons, that legacy of Tuskegee experimentation and just medical mistrust. But I think there may also be a role in communication failures. And this is a two-way street. Oh, I took the slide out. I'm sorry. I'll just have to give this verbally and add it to you. You may have heard about an African-American woman physician who died of COVID-19. She was hospitalized at one hospital, and then she was discharged despite the fact that she was reporting that she was short of breath and did not want to be discharged. I don't know. I took the slide out because I don't know the medical details. This is, there's a lawsuit going on. I don't know any of the internal communications, but she was discharged from the hospital, readmitted 12 hours later to another hospital, and died a week or two later from severe COVID-19. I cannot help but wonder about communication failures between the medical team that discharged her and this patient. I continue to wonder whether we're failing as public health, as medical people, in communicating what people need to know. What are their questions about vaccine? And I want to give you an example, lest we have hubris about, oh, don't worry, this has been thoroughly studied, we know everything and something is safe and there's no risk. Because there will always be future rare events and things we don't know. And I want to give the example here around blood transfusions. So in the early 80s, before HIV and AIDS were identified, there were a number of people who received transfusions who became HIV positive. They acquired HIV via blood transfusions. So to say in 1983, or to say in 2021 that blood transfusions are perfectly safe is not true. There are always viruses that we don't even know about yet. And so HIV, once there was a test available, Red Cross started doing antibody screening and the blood supply became safe. There's a similar story for hepatitis B virus, hepatitis C virus. Those rates of transmission via blood transfusion went down when we started testing for things. But it's difficult to say something is 100% safe. Nothing in life is 100% safe. I do want to bring up two other incidents. You may recall, you may not know the name for it, but the Qatar incident, this was the Salk polio vaccine. This is the killed vaccine. They were in a big rush to get it out, and the Qatar manufacturing plant did not adequately inactivate their vaccine, and some children got polio from the vaccine. I think 200 contracted polio, a certain number of those were permanently paralyzed, a certain number died. So that it is true that there have been past events in which people contracted the actual disease from the thing that's supposed to save them, from the vaccine. Again, none of these vaccines in the United States have whole virus. They cannot give you COVID-19. That's not true in some other countries. So we might get a report coming out of China, for example, but none of these vaccines will do that. You may have heard about Janssen and Jansen talcum powder, and that there has been a link. This is an epidemiological link. This is an odds ratio that women who use Johnson & Johnson baby powder on their perineum, on their private parts, have a higher odds ratio of ovarian cancer. There is a theoretical explanation for this, but it's certainly not proven. It could be that talcum powder was contaminated with asbestos. Johnson & Johnson says, no, it was not. I don't know the studies. I know there's a lawsuit. There's another theory, talcum powder. Oh, it's baby powder. Talc is a mineral. It's a fibrous mineral. And it, if it could travel up the the reproductive tract and inflame the ovaries, theoretically, it could be associated with cancer development. I just want to point out that when we hear crazy theories, we still need to answer them, because sometimes those crazy theories turn out to have a kernel of truth. And because if that's what people's questions are, they deserve honest answers. We need to build trust. If we won't even answer, if we'll just dismiss somebody's question, that's not going to increase their trust in our other answers. This is my last slide. This refers to keep the pressure on, with those mitigation measures. This was a study, a modeling study done out of San Diego County. So this is not a national study, but this was using their data because they have that B117 variant that is spreading quickly. So if you look at the upper left-hand corner, that graph shows if you kept on with current protective behavior, but no vaccination, what would happen? Well, the B117 variant would become the predominant variant. By end April, we would still have lower numbers of cases because good job, everybody. The number of cases is decreasing. We're keeping the pressure on, but it wouldn't go as low as you hope. If you had current behaviors, and now we're in the lower left-hand corner, current behaviors and a fast vaccine rollout, you could really get the number of cases down. Yeah, the variant would still be the predominant, but you could get the number of cases down. Now let's look at that graph on the right. Fast vaccine rollout, get it out as fast as you can, but relax those protective behaviors. Yay, we need to wear masks anymore. You're not only going to get a surge in predominance of B117, you're going to get a surge in the number of cases of B117 variant. Remember what I said, more cases means more death, even if the virus is not more lethal. So even after you're fully vaccinated, please continue to wear your mask, distance, until we can get enough people vaccinated that this turns out to be, we've got herd immunity and we're not going to be worrying about transmitting serious COVID-19. So thank you very much. Yikes, I see we have 32 in the chat box. So if those are all questions, I can stay on after 3 o'clock and I'm happy to do that. We'll try, and I see some of these are just people putting in their names. So let me go to the chat box and try and get through as many of these questions as we can. And as I said, I'd be happy to stay on past 3 o'clock if people are able to. So
you probably want to go ahead.
Go ahead.
I was going to suggest you may want to start with Laura Del Duca's question of for people that have had COVID, should they get the vaccine and is there a waiting period?
I see it. Thank you. So people who have had COVID, yes, you should still get the vaccine. Why do I say that? Because the antibodies that are produced by the vaccine, antibody levels were even higher for all three of these products than was produced by convalescent serum, produced by the blood tested of people who had the virus. I mean, they have like superpowered these vaccines to go straight for that spike protein. So yes, we would recommend vaccination. Is there a waiting period? So the minimum waiting period after you've had COVID-19 is you want to wait until 10 days, you're outside of that isolation period and you don't have symptoms. You don't want to get vaccinated when you're feeling sick. CDC suggests that it is safe to wait 90 days, not mandatory, but you would be safe to wait 90 days after COVID to get your vaccine because reinfection during that 90-day period is rare. But there's no reason why you can't get the vaccine whenever you are eligible for it.
The next question was around one person is having their staff tested each 2 weeks. Once they get the vaccine, is that still recommended?
So routine testing, if you work in a work setting that is doing routine testing, long-term care facility, we do it at DHEC, we do, routine testing. Even after you're vaccinated, we do recommend routine testing. And here's why. You can still get asymptomatic infection. You won't feel bad, but you may spread it to others who are not vaccinated. And remember we said vaccine efficacy was 95%, not 100%. So there are some people who may be vaccinated who might still get sick with COVID-19. I mean, it's a small number, but there's still that possibility. So you don't want to spread it to others. So if you're in a facility that is doing routine testing, even if you've been vaccinated, you should still participate in that routine testing to avoid spread to others who've not been vaccinated.
Great, thank you. The next question was, are 100% of long-term care of folks that are in long-term care facilities and staff, have they all been vaccinated?
100, no, because not 100% of long-term care residents and staff requested being vaccinated. Many turned it down, unfortunately. What we can say for residents, it was close to 70% of residents in long-term care facilities accepted getting vaccinated. And I don't think all of them have gotten their second dose yet, but we're pretty close to that point. And in terms of staff, unfortunately, it was less than 40% of staff accepted vaccine. Now, we're not done yet, so they might still, and they can change their minds, right? I mean, we stopped the long-term care facility program, that they would still be eligible to go on and get vaccinated at their local pharmacy or physician's office.
The next question was around who decided who would be included in what phase?
And when it began. This conversation has been going on for a long time. In September, we started, South Carolina instituted a vaccine advisory committee, which had representatives from about 24 agencies around the state. It included healthcare providers like South Carolina Hospital Association, it included insurers, Blue Cross Blue Shield, for example, also groups representing different community entities like AARP for older adults, National Urban League for African Americans. But, we had disability agencies. So we tried to be inclusive. You can't include absolutely every entity under the sun, but we tried to include a diversity of voices to help us understand needs in the community. But we also looked at the evidence base, like I mentioned, mortality and comorbid conditions. What information do we have coming out of CDC? There was also something called the National Academy of Sciences Framework for Equitable Allocation of Vaccine. It's a 238-page document that was put together by a group that took a tremendous amount of community input nationwide, and they had specific recommendations. We used that as our starting point, and have been working for months, going back and forth on who we would want to have in phase 1B and 1C. And then finally, ACIP, the Academy Advisory Committee on Immunization Practices. This is a group that's organized by CDC, includes a number of people outside of CDC. They made their recommendations at the end of December. Their recommendations were to have phase 1C, 1B be frontline workers, but 1C be the people with the medical conditions I mentioned, as well as the older adults. In South Carolina, we had a lot of concern about what our main goal is to reduce mortality. We've got to address the older adult population and people with medical conditions. And that, the Vaccine Advisory Committee is an advisory group. DHEC made the final decisions. These final decisions were made in conjunction with this discussion. They made recommendations, but the final decisions were made by a small group of people at DHEC in conjunction with discussions with the governor. So that those decisions were finalized last week based on vaccine supply, that we're getting increased supply now, especially with Janssen vaccine available, with demand. We were finding that phase 1A, we were having some clinics whose appointments were not all filled, so it was time to move on, and just increasing information about risk.
Ben, I'll ask you a quick question. Do you want to say something as we get to the end of the hour? And then Dr. Kelly said that she has the ability to stay a little bit longer.
Yeah, absolutely. I mean, on behalf of Together SC, I do want to thank Dr. Kelly and for her time and this great information. I mean, I've learned several new things, and my head is just chock full of it. Graham, thank you so much for introducing us to Dr. Kelly and helping us arrange this call. Just to remind folks, we will have the recording of this posted and sent out. And Dr. Kelly, I believe, has graciously agreed to share her slides with us in order to get this information out. So if you missed anything, don't worry, that information will be in the follow-up email that we'll send out in a couple of days.
Great. Do you want to keep going and since she has time and just let folks stay on that would like to?
Absolutely.
Okay,
And,
great.
and actually, I feel like the remaining questions I can do pretty quickly. There are a number of questions about people of color involved in the studies. And I know the slide I showed sort of lumped a lot of people together. The number of people, in communities of color tested in the United States in those phase 3 trials were fewer than the proportions of the populations in the United States. But, honestly, an awful lot of medications and vaccines, the predominant phase 3 people are white men. And they made a real effort to make sure they got women and ethnic minorities included in these trials. And in terms of the exact breakdown, that information is available. Both the emergency use applications that Pfizer, Moderna, and Janssen publish, they're all available on the FDA website. So if you really want to get in the weeds, I mean, some of those applications are 70 pages long, but they have all the tables with the exact breakdown of how many people are in the study, what were their exact results. The other thing I failed to mention, but I want to make sure you understand, when I talk about vaccine efficacy, they also broke it down not just by where people live. They looked at it by age and by race, ethnicity, and comorbid conditions. So by age and race, ethnicity, all of those vaccine numbers I quoted, it was true across the board. So when I say, 95% efficacious for Pfizer and Moderna against any symptoms, or when I say 85% efficacious against severe disease in Janssen, that is true regardless of age, that is true regardless of race, ethnicity. It's a little bit lower if you have multiple medical problems, but still excellent but still keeps you out of the hospital and out of the morgue. Why did we have such a low flu season? I think because people were masking, keeping distance. I mean, this is a real lesson that we can keep flu down by those same mitigation measures. How long does vaccine last? What do we know about this? Well, since we don't have vaccine out for more than a year, we're a little bit limited in what we can say. What I can say is those phase 3 studies that started back in June, a lot of those people that have continued to be studied still have high levels of antibodies 6 and 8 months later after vaccination. And remember, it's not all about antibodies. Antibodies eventually will decrease, but they decrease because your body doesn't need to keep making antibodies if you're not, recurrently infected. What happens though is your immune system also has something called memory cells. Those memory cells, and they're B cells and T cells, they remember being exposed to the spike protein. They last years. For some vaccines, they last lifelong. We don't know yet how long these vaccines immunization will last. We think at least a year. It may be much longer than that.
Well, I think that's all the questions. So again, I thank you so much, Dr. Kelly, Graham, all of you on the call today. Really appreciate it. It's phone calls like this that help us keep the nonprofit network together. So we have plenty of other opportunities where we're all getting together and learning together. So please check out our calendar at togethersc.org and sign up for any other sessions we might have in the future. Thank you so much.
Great. Thank you for inviting me.